It's a great pleasure to welcome Dr. Jane McCarthy to Toronto and to introduce her today. Dr. McCarthy is consultant psychiatrist in intellectual and developmental disabilities in London, England. She's a fellow of the Royal College of Psychiatrists in the UK and is currently vice chair of the Psychiatry of Intellectual Disability faculty at the college. This is a vibrant and growing faculty with over 900 members. She is visiting senior lecturer in the Forensic and Neurodevelopmental Sciences Department at the Institute of Psychiatry, London, and honorary senior lecturer at University College, London. Dr. McCarthy has worked in community and in inpatient settings and with a diverse range of individuals with intellectual disabilities and autism, coming from different ethnic and cultural traditions, across the range of abilities and severity of autism, and across the lifespan. In essence, similar demographics to people with autism here in Ontario. She has also worked in secure settings with patients with autism who have come into contact with the law because of their behaviours that challenge services. She has researched outcomes across the lifespan of these individuals who, in addition, have psychiatric disorders, and has published over 60 peer-reviewed research papers and chapters, edited several textbooks, and presented at national and international conferences on these issues. She's also co-editor of a new journal, Advances in Autism, to be launched next year. The UK, where Dr. McCarthy comes from, it has a long track record of research, education, training, and clinical service development related to people with intellectual disabilities and autism. However, in 2009, England took a further bold step forward with the Autism Act, the first ever disability-specific law in England. This puts duty on the government to produce a strategy for adults with autism and to produce statutory guidance for health and social services to implement this strategy. Dr. McCarthy has played a significant role in these developments. She's acted as clinical advisor for adults with autism at the Department of Health in England, supporting development and delivery of this national strategy. I have heard Jane speak on many occasions. She robustly researches the literature and applies this to clinical experience on the ground and brings a chard of clarity to often confusing and not infrequently contentious issues, such as those that arise in mental health and autism. Perhaps as we sit back and listen to her perspectives from a broad range of experience working in this terrain, we will be re-energized in our efforts to best support Ontarians with autism and mental distress. So thank you, Jane, for accepting our invitation to speak today.
Thank you very much for the invitation from Dr. Weir and from Kevin and from Elspeth, and it's a great honour to be back again in Toronto. My remit today, and I think a lot of it, in a way, has already been covered this morning, is to look at the issue about diagnosing and assessing mental health problems in adults with autism. I'll just say that I haven't really got any conflict of interest, though I did work for an organisation called St Andrews Healthcare, which was the biggest provider of secure forensic services for adults with autism in the UK. And I've come from a field of training in British psychiatry, a generation that was influenced by Sir Michael Rutter. So we've probably got a strong background around autism. Also, there was a professor at the University of Edinburgh called Robert Kendall, who basically emphasised the importance of taking the time to get to the right diagnosis so that you would actually then know what to do next. So this talk will very much emphasise that diagnosis and assessment. And because I work in forensic services, I thought I'd just tell you a little bit about the people that we meet with autism and spectrum disorders across the criminal justice system, and just briefly tell you about some service developments in the UK. I'm not going to go on about DSM-5 criteria, beautifully covered by Professor Bailey this morning, but a little bit disappointed from a clinician's perspective because I don't think it really gets across the complexity of the people we see on a day-to-day basis. And I think, this triad of difficulties which has been described by Lorna Wing, which very much talks about the difficult of the inner world for people with autism to talk about their inner emotions, the difficulties in predicting other people's behaviours, and obviously the work around understanding facial expressions and use of gestures. And I think what these difficulties show us in working as a psychiatrist or working in the field of mental health is how difficult it is to sort of unravel what are the core difficulties of the individual with autism and what is a mental illness that we need to do the next step in terms of interventions. So I've been asked to talk about comorbid. And, you know, in England, we're very much emphasised that we come from a very developmental background in terms of our psychiatric training. But I just feel that you need to sort of have some understanding when you meet an adult where they might have been in terms of childhood and adolescent difficulties. And the common problems in childhood is more around ADHD. And people say that 50% of young people with autism have symptoms. Whether they have what we might call the disorder is debatable. Emily Simonoff's work in South London shows that significant children in a clinic setting who come with autism, the common other conditions are social anxiety disorders and oppositional defiant disorders. Working within ICD-10, we're allowed to make more than one diagnosis. Well, obviously, some of these diagnoses are excluded if you have autism within DSM. And then, obviously, depression is the common condition that we see in adolescent years. If you work like I do, predominantly in the field of intellectual disability now, you see this worsening of the challenge behaviours through the adolescent years. And this is a really vulnerable time for people with autism spectrum disorders. And the challenge behaviours are okay as a child. When you come to become a teenager or adolescent, they become much more difficult to manage on a day-to-day basis for the family. But we've already sort of talked about what are the types of disorder in adult life, and everyone's told us that depression and anxiety are common, and they're common for people with autism. But the literature talks particularly around these other conditions such as OCD, schizophrenia, because I think they're so difficult to tease out and diagnose. And I was going to specifically mention around catatonia, because this is another particular condition that's reported in the literature for adults with autism spectrum. And I think we've already talked about to some extent, but I think what we need to realise that when you are assessing a person with autism spectrum, that they will struggle to talk about their inner world and their emotions, and that they have problems understanding the questions we ask, and they take everything at a very literal level. And the constant challenge for the physician or the psychiatrist is trying to distinguish the features of autism from mental illness. And I think that's why the presentation this morning by Professor Bailey was so useful, because it told you what are the core difficulties and symptoms of people with autism. And I think you have to understand those difficulties before you can then try to assess the mental health symptoms of an individual. And the important probably message from this slide is that you really need to obviously talk to the person with autism and get some understanding of their experiences. But it's also important to meet with somebody that knows them and has known them when they've been well before the onset of the illness. And have the luxury of being able to access early health records, child and adolescent records. And maybe that's a little bit more easier in countries where than other parts of the world. And this is a very complex area, and you can't rush it. You have to take your time. And complex cases do require more time. And I don't think you can really get away from, and we've been trying to figure this out in the United Kingdom, how do we enhance our general adult psychiatrists to understand and diagnose autism and then recognise mental illness? People say, well, it's okay for me for being a specialist in the field of intellectual disability. I get 4 years of training to see people with developmental disabilities after I've done my basic psychiatry training, and I get trained particularly around people with autism. But that wouldn't happen for someone that's gone through a more general mental health psychiatry route. And I think we've also already talked about the fact that if you see somebody with ADHD, or you maybe see someone with schizophrenia in adult life, it may blind you to the fact that you've got somebody with autism also sitting in your clinic. And I think unless you have some recognition or understanding of recognising autism, you might still remain blind to the underlying developmental disability the individual might have. And, you know, I'm stating the obvious here, but I think you do need to see autism in its various manifestations. And already someone took my quote earlier today, one of the parents, and I think it comes from Fred Volkmer. If you've seen one person with autism, you've seen one person with autism. And, you know, you've got to really be familiar with a range of psychiatric presentations of mental health problems in people with autism. And I do think you've got to come from a very developmental perspective. And, you know, it's interesting that, you know, probably other parts of the world, certainly in Europe, that a lot of the adults with autism are seen by child psychiatrists, because I think they understand that developmental perspective. And, you know, people with autism do experience the world differently. We've heard some beautiful descriptions this morning of what it's like to have autism spectrum condition on a day-to-day basis. They do have different brain structures, and they have these also sensory issues. And I think the constant question you keep asking yourself as a clinician, is the depression I'm seeing, is the ADHD I'm seeing, is this the same condition I would see in other people in the wider population? Or is it a sort of atypical form, or has it been modified in a different way because this person already has a pre-existing developmental type condition? These are some basic tips. It's really, you know, someone was talking about the person with autism having to go to school, manage school, and then manage everything else. And I think it's the same for an adult with autism coming to see you in a clinic. They've got to manage coming to the clinic and then tell you, I've got these symptoms and these problems. And, you know, one of our things from our national autism strategy was to make reasonable adjustments for adults with autism. And that's just not making the physical environment okay. It's also about the clinician having the communication skills and modifying their behaviour to meet the needs of an adult with autism. And some of these things I've listed here, you know, obviously encourage somebody to come with them, but keep the interview to a reasonable length because it's quite stressful. And, you know, note any sensory difficulties about light or noise, and allow the person time to answer your questions, because people with autism have working memory problems. They might echo your question back before they get to what they need to say about your question. So really, you know, you've got to be patient, take your time. This is not a rushed process. It's complex. People ask me what's the difference between maybe here and the United Kingdom. Well, basically, we work in multidisciplinary teams. We don't ever work on our own. It's very unusual unless you are in private practice. I work in the National Health Service. This is a publicly funded central taxation healthcare system. And we're paid really much about how much we deliver in terms of a team. And, you know, the fundamental issue that needs to be sorted out first in adult life, and this was part of the national strategy, that we need to make sure the person's actually been given the diagnosis of autism if they have it, and that they have had a clinical assessment by somebody that sees people with autism, and also, you know, have the assessment with the support of diagnostic tools. Obviously, I have psychologists, so I can get access to people's cognitive profiles, which is very helpful in terms of modifying treatments. Sensory profile, is this all, you know, anxiety issues driven by sensory issues, physical health issues. People talked about, I'm not going to go a lot about investigations. We basically don't, you know, we're quite restricted in how much resources we can call on. But in terms of blood tests, we tend to do that if we think we're going to start medication. I was interested in the challenge about genetic testing. That's still not routine in the United Kingdom unless there's something else like a learning disability, some sort of facial or other factor that indicates that you might be looking at a genetic condition. But I do take it on board that Fragile X should be seriously considered. We don't do routine neuroimaging unless we think there's something additional going wrong in terms of neuroscience. So it is very much about a standard clinical assessment. And that's in addition to you doing your psychiatric history and your mental state examination. There are assessment tools for assessing psychiatric problems in people with autism. I don't use them, but I've listed them on this slide so that you're aware of them. The first one was basically developed for children and adolescents. The second one by Johnny Mattison in North America. It's more been developed as a screening tool to help carers, people, family members, to recognise when there might be some sort of mental health problem going on. And then there's the PAC from Norway, which is completed by the informant, but most of it's just really reported on people more severe to profound intellectual disability. Mental state examination, I'm not going to focus on too much on this, but if I could put this up and say that person has autism, or I could put this up and say some of those presentations and symptoms are parts of mental illness. And I think Professor Bailey spoke this morning about picking up that social interaction with the patient, whether they, how they interact with you, where and someone talked about their son this morning on the panel. You could have half an hour conversation, but you maybe not got a lot out of that half an hour conversation. So there's sort of like the flags that you maybe need to think about if you're seeing somebody in a sort of mental health setting, that they might have an underlying autism spectrum condition. This is what's the reported prevalence of psychiatric disorder in people with autism, obviously much higher than the wider population. This is taken from a Royal College Psychiatrist report in the United Kingdom, which I've referenced at the end. And it's basically a document to enhance the knowledge and understanding of autism for general psychiatrists, non-specialist psychiatrists. But the message they want to get across is that the common mental health problems are common in this group, and they occur much more often. And if you go into clinic studies, the work by Gazudin in the United States of clinics for adults with autism, you get very high rates of mental health problems. But when you're, obviously I'm a little bit more interested in people with intellectual disability. Elsa Bradley did this work on a community-based study in Canada, and she found that those with autism had 5 times more episodes of mental health problems than those without autism. And but when you go into adult life, into clinic studies or community-based studies in the UK, there isn't a great deal of difference. So there's something about the teenage years that really is an at-risk period. So what I thought I'd do is just go through some of the symptoms and presentations on common mental health problems. And this is a review of over 20 years that was published now nearly 8 years ago. And there's no surprises there. People with autism come with the same symptoms of depression as everybody else, common one being depressed mood. What they really wanted to emphasize in this paper is that the sort of maladaptive behaviours or the autistic symptoms actually might get worse through a depression. And that might be a sort of flag up that you've seen something else going on in terms of a mental health problem. So what you expect to see in other people, the symptoms are very similar. And someone gave an example of the young person, the multiple diagnosis they got. It was a bit scary listening to it, to be honest. And I think what happens is, I think when you pick the person up in young adult life, they've already been through a multiple of seeing other people and trying to disentangle what was the initial first presentation of the mental health problem can be quite difficult. This is where I advocate greatly for going back to the original health records. But I think what happens is a lot of people, and this is my experience, young people with autism spectrum conditions, they get some sort of brief mental health problem, particularly when they go from school onto college or they're transitioning out of children's service into adult services. And they get a brief, they might get a stress disorder, they might get an adjustment disorder, they might get a psychotic episode, it might look like a mood disorder. And it's really difficult to disentangle what's going on. And some research is just not quite published, but was reported recently at another conference I went to, does suggest that in young people, autism may be a risk factor for a bipolar disorder, even compared against their siblings. And my clinical experience is if I do see psychotic symptoms, clearly psychotic symptoms. I think more of a mood disorder in someone with autism before I think about schizophrenia. But I'm happy to hear other people's experiences. And we've had a lot of conversation this morning already about anxiety disorders. I hadn't actually put social anxiety disorder onto the slide. And I think, well, I don't know if I say we under-recognise it or we don't diagnose it, but obviously anxiety conditions is almost inherent in the difficulties of having autism and trying to operate on a day-to-day basis. But the question, and a lot of it could be around the sensory issues, people changing routines, and it can really impact on the ability of that person to function, to get on and do things on a day-to-day level as an adult. The question comes, do I say that is a social anxiety disorder like everybody else and go through a pathway of treatment and interventions, or do I see it as something related to the core difficulties of their autism, and I need to put in some more support, whether it's around employment, housing, support to the family, and really give advice to carers. Please don't keep changing the care staff around that individual. Please don't take them on a different route to their day services. Please don't bring a lot of demands into the environment, because you will get anxiety symptoms. And I think that's the issue around having a real clear knowledge and understanding of autism, and sort of having the confidence to challenge the carers around them. The OCD issue, would I like to duck it? Possibly yes. I think it was called a bit of a quagmire this morning. But I definitely think that people with autism do meet a threshold for OCD. And, there's this genetic link where there's increased risk in relatives. And obviously it's this business again where the core symptoms of autism look like the core symptoms of the mental health problem. This is a very old piece of study in 1995. There's not really a lot out there that helps you, if you weren't seeing it on a day-to-day basis, of a clinician to guide you in the right direction of whether you're seeing OCD in addition to an autism spectrum condition. And I suppose I tend to diagnose an OCD if I do see this, what I would call this cleaning behaviour. So if I have someone with autism who spends about 2 hours in the bathroom and doesn't come out because they have to go through lots of routine of washing their hands and cleaning themselves, then I would think, yes, that looks like an OCD condition. But if they're just really interested in having things in an orderly fashion, it's not really impacting on them in a day-to-day basis, it's not causing them too much discomfort or distress, then I probably think that's something to do with their autism, and do I need to do anything about it? Is it causing a problem for them? Is it causing a problem for the people around them? So hopefully that's sort of given you a feel around the conditions of depression, anxiety and OCD. I think we see a lot of psychosis and schizophrenia in South London, maybe related to what's available on the streets. But certainly people have debated the relationship between schizophrenia and psychotic illnesses and autism, and the original work by Professor Colvin in the 1970s, and Judith Rappaport's work, which shows that certainly childhood schizophrenia, a very strong link to autism conditions. And there's some recent research that suggests that children with autism are more likely to have a family history of psychotic conditions. Does that help me as a clinician? I think the diagnosis of psychosis, I've listed here, the shared features in terms of social interaction, and that was talked about a lot this morning. I think the problem comes when people with autism have quite unusually bizarre or rigidly held beliefs. Someone's talking about the son talking aloud, the experience of getting someone with autism to tell you about auditory hallucinations, or really is it the misinterpretation of their inner world? Very challenging on a day-to-day basis. You sort of get thrown into the pragmatic approach. And I think, one of the signs is this is the business about knowing the person when they're well, having an informant to tell you what it looks like, what that person looks like when they are well, is that, you know, if you get some significant loss of functioning with some sort of bizarre and changed behaviours, that might indicate that something more is going on. DSM-5 clearly states that if you've got ASD, you can only make a diagnosis of schizophrenia if the delusions or hallucinations are prominent. So it's basically saying you've got to be really convinced that you're seeing delusions and hallucinations, you're not seeing some sort of symptom of their autism before you hit the button that says they've got schizophrenia. I'm happy to hear other people's views and experiences on that. I'm just going to give you two people that I might probably see day to day in clinical practice. They're all young adults, examples. They're all with autism and borderline intellectual functioning. So here's Mark. He's preoccupied with the girl in his classroom, believes she loves him. He's unshakable in that belief. He neglects everything he does just to look at her Facebook page. You might think, young man with autism, starting to understand relationships. Someone puts him on some antipsychotics, and they're able to really reason with him. And he's a bit upset that he realises she doesn't actually love him as much as he thought. So that could be, yes, a delusional type disorder. You see how it's complex, it takes time, you have to look at the subtle issues. Then Hannah thought I'd better present a female. Again, they're always young adults, goes to college, becomes very anxious, talks of voices. So you think, oh, well, maybe she's under a little bit of stress, adjusting to college. Someone puts her on a bit of a low dose of antipsychotics, maybe thinking she's just a bit anxious. This might be questioning the appropriate use of medication. I know we're going to have a talk later about medication. Then she returns to college, very fearful, reports other students are interfering with her studies and starts to deteriorate in functioning. I think you're seeing something more here. And I think it's that build-up of the presentation, the pattern of the presentation over time that's indicating you're seeing something of more serious type of mental illness. And then sort of one of the final things I just wanted to mention in particular specific conditions is catatonia. Now, this is work that's been described by Lorna Wing and Judy Gold. They run a national centre. Well, Lorna's obviously not here, but there's a national centre that's still operated by our National Autistic Society. And obviously, being a national centre, you get skewed referrals. But they were saying that there's this condition of catatonia that comes on in the teenage years. And obviously, you know, I put up the symptoms of what catatonia might look like. And that they're saying that this is a distinct condition, not just linked to presentation within schizophrenia or within a depressive illness. I don't know. I mean, I think there's something about the biological and psychological changes that for adolescents, again, you know, more evidence that it's a very vulnerable time for young people with autism spectrum disorders. My experience is I've only ever seen catatonia in someone with autism, where I've then gone on to diagnose a severe form of depression, but I'll be, you know, for the people who've got other experiences. And we wanted to know really whether, because obviously I work in the field of intellectual disabilities, were the people with autism, though they might have similar prevalence as those without autism, had a different pattern of problems. It's very difficult to find any research that doesn't involve the group with intellectual disability in sort of clinic-based settings. This is a clinic in South London and Maudsley, very big clinic, population of over 800, and we use ICD-10. All the psychiatrists who work there have been trained to see people with intellectual disability. And as you can see from the slide, that there wasn't a lot of difference, except that ADHD was much more common and anxiety disorders much more common, but, you know, no surprises either. And dementia was less so in the non-autism group, and I'll come back to that. But I think basically the autism group were a much younger group, and that probably skewed the prevalence for dementia. So really, this study just says what we already know, that ADHD and anxiety is common. There are a lot of other conditions I could talk about. We've already talked about the fact that eating disorders, you commonly find women in those clinics. Dementia, very little work done around ageing people with autism. What little bit of research out there doesn't suggest that they're any more at risk for dementia. And then obviously conditions like tic disorder, Tourette's, with a significant overlap. And I am going to mention about substance and alcohol misuse. I know it's already been asked about. It's actually not a lot out there. It's more actually in North America, and it's mostly around alcohol. And as rightly pointed out this morning, it's really to cope with the day-to-day difficulties of life, the day-to-day stressful situations of, getting out there socially, the bullying, sort of work done by the National Autistic Society in UK about people who've been to mainstream education with autism. Every single one have been bullied at school at some point. We were just doing some work in a South London prison. We're looking at autism, ADHD and intellectual disability, but basically what this slide shows, and it's unpublished, so it's got a little reserve on it, but if we asked about high alcohol use or any drug use in the last 12 months between prisoners without any form of a neurodevelopmental problems and those with autism, there wasn't actually a great deal of difference. What we did find, though, that the autism group that were reporting high alcohol or high drug use, the great majority also had an additional ADHD diagnosis. So it might be that is the real risk factor for the substance misuse. And it was very interesting to hear the presentation before lunch. Hard act to follow, but I think sort of alluded to that a little bit. I know that Jan Lasky has done some work around self-harm and suicide. Still very understudied. Very linked apparently to abuse, bullying, and obviously common with depression and other mood disorders. And it's probably makes the risk assessment quite difficult, because obviously trying to get the inner world and the understanding of the individual. But, you must do risk assessments around suicide and self-harm with someone with autism, particularly if they're presenting with a mental illness. I'm not spending too long on this because I think we've already been through it, but, obviously first-degree relatives of people with autism are at much more risk of depression, OCD, and a number of other conditions. What I would like to emphasise is this slide, that life events have clearly been shown to be a risk factor for people with autism, as they are for the rest of the population for mental health problems. And, loneliness and this bullying is a significant psychological factors. Very little work has been done around the impact of their early family life, such as, adversity, deprivation, which is obviously quite common in looking at for other people in the wider population. And having worked in secure forensic services, you definitely see this group. The people that we have low and medium and high secure, the people that get into a medium secure specialist autism inpatient unit, I could say practically every single one of those has come from a very adverse, abusive, traumatic early life, on top of their autism, on top of whatever mental illness they've got. So a real risk factor for getting into the criminal justice system. And I was asked to sort of talk briefly about challenge behaviour because I'm an ID psychiatrist and I might know a little bit more about it. And all I've done is put on this slide something from which I'll reference later. We have something called the NICE in England, in the United Kingdom. They are the National Institute of Clinical Excellence, and they put guidelines on everything that we're meant to practice on. And they're basically saying that if you see challenging behaviour, you really need to not just exclude a mental disorder, but you really need to think about the physical environment, sensory factors, physical disorders, other neurodevelopmental conditions, ADHD, in a person presenting with autism spectrum. And, obviously do basic factor analysis approach. I'm not a psychologist, so I won't go into too details. And the reason I'm sort of emphasising is because we looked at this again in an ID population about the relationship between mental illness and challenge behaviour. It's published. We use some standardised tools, which you can ask me about. But I'm just want to give you the findings, really, that basically challenge behaviour wasn't associated with a psychiatric disorder in those with autism and intellectual disability. So what I'm saying is, look for those other problems. don't look for a mental illness, because you're more likely to find the other sensory, environmental, change of routines, physical health problems to be a more likely cause of their underlying challenge behaviour in a person with intellectual disability. And for those with intellectual disability that presented with challenging behaviour, the most common reason would be that they also have autism. Nothing rocket science, but we sort of proved what we felt was felt right clinically. And we did a little bit more of an in-depth study. My PhD student did it at the time. And obviously the group with autism had much higher rates of behavioural problems. But when you drill down to what those behavioural problems were about, they were much more around these core autism problems, around communication, social relating, being self-absorbed, rather than other sorts of like depressive anxiety symptoms. So those challenging behavioural problems are related to the core difficulties of the individual with autism. So, keeping pretty much time, yeah, okay. So, whistle-stop tour of mental health and challenge behaviour, but obviously I'd like to talk a little bit about forensic aspects. We've been trying to struggle in the United Kingdom to see if people with autism are more likely to be in our prisons, our secure hospitals. They're definitely more in our secure hospitals, probably not because more get in, but it's just a lot more difficult for them to get out again, because people just don't recognise what their difficulties are, so they can't rehabilitate them very easily. It's ambivalent about the prison. There's a United States study saying that there's more people with autistic traits in a particular prison. There's a Swedish study that showed people coming for forensic assessment, about a significant number had autism. Again, this is a very vulnerable period of adolescence. And if you look at the people that get into our secure hospitals, they all started their problems at like 12 or 13. They started to have contact with the criminal justice system at that age. The pattern of offending behaviours is very much the same as everybody else we see in the secure hospital. Number one is violence. Number two, sex offending. People talk about fire setting. When you try and do a research study, trying to find people with adults with autism who are fire setters in secure services, you just can't find them. So, but obviously people talk about these other types of crime related to obsessive behaviours. And then the one that sort of gets out there are the computer crimes. We had somebody, very high-profile scenario in the United Kingdom, who got into the Pentagon defence system, and they tried to extradite him. And there was obviously a bit of a battle between us and the United States over that issue. But they're the ones that sort of hit the public arena. But there has been some work that people have done in the United States. I know it's only small numbers, about the link between violence and autism. But it does seem that if someone with autism does commit violence, which is sort of linked to other wider population studies, that psychiatric disorder is probably quite common. So it's that if you get autism and then you've got a psychiatric mental illness and then people don't recognise it, treat it appropriately, it might increase your risk to get into a offending criminal pathway. People have also looked at psychopathy. This is a work by David Murphy, who's a psychologist at one of our high secure hospitals, to see if the people with autism have got into the high secure hospital are more likely to get a psychopathy diagnosis. Are these things all coming together? On the whole, no, they weren't more likely. This is, using the PCLR, but they're more likely to have some of these particular difficulties around empathy and remorse and accepting responsibility. So they're not necessarily in there because they've got psychopathy in our high secure hospitals. We looked, when I was working at St Andrews, we tried to compare the people in the low secure autism services to those in the services for the more forensic mental illness population. What we found, as again this business about they had much younger age at contact with psychiatric services, and a significant number had schizophrenia. So it does seem that significant severe mental illness really is a risk factor, possibly getting you into secure hospitals. Interesting, alcohol and drug use was less common in the autism group than the sort of more forensic mental illness group. We've just been doing some work. This is a study I've talked to you about before. We want to look at people with autism in prison to see how vulnerable they were regarding mental health problems. going to sort of skip these next couple of slides, but we use something called the AQ20. Probably Professor Bailey sit there in horror. But we used the mini psychiatric interview. We got to 240 of these prisoners, significant from a black minority ethnic background. We found this normal distribution of AQ traits. I don't know what it would look like in a population outside of prison, but it's interesting. We used the cut-off score of 10 because that's what Simon Baron-Cohen recommends. We had to use the ADOS. We wanted to use the ADI, but everybody in prison is disconnected from their family, so we couldn't do it. Occasionally I did a telephone interview to a disconnected grandmother to try and get the developmental history, but we just gave up. So we just had to modify the ADOS to use it. But what we did find, and obviously, it's unpublished work and we have to have it further scrutinised, is that those with autism were much more likely to have a current episode of depression against the other prisoners without any neurodevelopmental, 30% against 6%. And those with autism were much more likely to have a generalised anxiety disorder. Because some people argue to me, if I go and see someone with autism in a prison, why are you bothering coming to bring them out into a secure hospital setting? It's quite a nice, organised prison. Person with autism probably do quite well there. They like the routine. They like the structure of a prison setting. I'm saying I think you'll find they're quite vulnerable there, actually. And I think they have quite high rates of mental illness against other prisoners. I think this one's very interesting, actually, in terms of suicide and self-harm. They had significantly higher suicide scores. 24% have thought about self-harm against 5% of other prisoners, and 15% actually injured themselves in the past month against 1.5% of other prisoners. Really high-risk scenario for them to be in a prison setting. But, that comes back to all the things I've said already about picking up and diagnosing people. They asked me to talk about women with autism. I'm not conscious of time. Basically, it's in the handout, but most of the work hasn't showed a lot of difference between men and women with autism. We did this is in an ID population. We found a bit more personality disorder and schizophrenia in males and females, and men were more likely to be given drugs. But, that's just sort of similar if you went probably to a non-autism population. I picked up this study around borderline personality disorder. We call them emotionally unstable. But someone went into a clinic for borderline PD and found that 15% of the patients met the diagnosis for ASD, which is this a misdiagnosis scenario? Again, there's some difference between the substance misuse less likely in the autism group. And, it comes back to this issue of diagnosis again. A lot of common features: impulse control, interpersonal difficulties. Do people with autism get misdiagnosed as borderline personality? To be honest, before I went into work in forensic secure settings, I couldn't buy into the idea that you could diagnose borderline personality disorder in someone with autism, but then I saw it. It gets very difficult to tease out what is driving the sort of challenging behaviours in terms of, what people might call their interaction with staff, or is it something to do with their autism difficulties? I've got a few more minutes, have I? Yeah. And in terms of development, so it is complex. It really is complex. The development of services, as Elsie's already said, we've got an Autism Act, and we've got a national strategy. And we had to produce this national strategy by April 2010, conscious of the fact that on May the 11th, a new government would be elected. And we did the strategy under the Labour government, and they're very much into nationally driven down policies initiative. And we had something called a conservative government, well, a conservative-led government came into power, very much about driving up everything from the local level. It's debatable. But basically the national strategy vision, we couldn't solve all the needs of people with adults with autism. We couldn't really delve into this complex mental health issues. We couldn't delve into when they got into the criminal justice system. But what we could say, and it's a vision, and a vision's always aspirational, is that it's here, that adults with autism can get a diagnosis and support if they need it. And they can depend on mainstream public services to treat them fairly as individuals, helping them to make the most of their talents. And what does that look like in reality? Well, obviously there were 4 key areas, but that was basically saying that every police officer, everyone working in a housing, everyone working in mental health services, everyone working in an A&E department, everyone working in a GP surgery knew something about autism. And we also focused on this planning of transition into adult services because, you know, someone asked the question this morning, if we really invested in children's services, will that make a difference? Well, we won't probably know that for some years. But I think, you know, if you had to prioritise where the resources went, I think it would be from the transition from adolescent to adult services. We have our National Institute of Clinical Excellence guidance. We had the children's one first, and then the adult one came out to the national strategy. That's got all you want to know about diagnosis, screening. I mean, they say use something called the AQ10, but, you know, the evidence around it is very limited. But that's really to help the GP in their primary care setting. So if you get a score above 6, you should be referred on for a diagnosis. But there were people who get a score below 6 who've still got autism. But you can download all this for free. There's the website. So to conclude, people with autism have experience a wide range. They mimic other psychiatric disorders. It may be very atypical. Adolescence is a very high-risk time. And it's easy for me to say from the United Kingdom, but you know, these people deserve a really quality assessment. You don't want the scenario that was relayed to us this morning where you ended up with about 8 or 9 diagnoses before someone realised what you really had. I think it's really important to involve the family, the carers, the informant. We're constantly struggling with, do we get a load of specialist psychiatrists out there that know about autism? Or do we train up our general psychiatrists and mental health services to at least do the bread and butter of recognising autism and common mental health problems? The national strategy is left a legacy that we have specialist autism teams, but most of these teams, rightly so, are focusing on diagnosis, support to the individual to get into employment, to housing, not necessarily having psychiatrists in the team. And I think, obviously, these are complex conditions that need some more research over time. So there's some key references, including the document from the Royal College Psychiatrist. These are the people that helped me with the research and some of the funding, and happy to take any questions. Thank you very much.